Thank you and welcome to the No Fear Work Package 4 webinar on supply chain. I will start sharing my screen now. Does everyone see the presentation mode? Yes, okay.
Yes.
So thank you again for joining us. We are going to hear today about supply chain challenges during COVID-19. And just to let you know that since the issues around PPE, personal protective equipment, have been discussed on several occasions, we are not going to focus today on PPE issue, but on other issues around supply chain that we believe to a degree were underestimated during COVID-19. I will just give an example that thanks to Chief McCoy and the team of the Fire Chief Association, International Fire Chief Association, we realized, we never thought about it, that one of the issues during COVID-19 was around electronics. And nowadays, because of all the new versions and the new electronics items, no one has basically spare parts. We are just doing just in time, with the idea that if ever we need spare parts, they will be flown within 24, 48 hours from the other side of the globe. This is our basic working assumption. And then COVID came and there was a dramatic decrease, even cessation of flights, and you could not get your spare parts from China that was closed. And radios and other electronics that broke down, and they break down, this is our daily life, you could not replace them. So we are looking into these kind of challenges and how they are being solved, or ideas about how they're being solved, both from the supplier side, and we are very proud to have two suppliers today with us in this webinar, and thank you, Natasha and the team working with our networks for making this happen. And we hope to see more suppliers and vendors in our future webinars, because this is one of the objectives of the project, and from the end user side and from the government side. So for those of you who are not familiar with the project, very shortly, Project No Fear is a 5 years project funded by the European Commission that started with the idea that we are a highly fragmented market between private sector, public sector, research, academia, vendors, and we don't communicate well. We do our business in a silo mode, and there are no common methodologies, and we are trying to bring some remedies to those issues throughout the dialogue that we are creating in the project, and we are extremely proud of the dialogue that we have managed to create in the project. No Fear is working around three major pillars. Work Package 3, led by our colleagues from Policlinico Gemelli in Rome, is dealing with the acute care of the patients. Work Package 5, dealing with training and education, led by our colleagues from Crimedim in Piemonte, and they are also the project coordinators. And Magen David Adom is proudly leading Work Package 4, who is dealing with the operational side. And I did not introduce myself. My name is Chaim, and I'm the disaster management coordinator of Magen David Adom and the leader of Work Package 4, together with Itamar Leist, who is also on this webinar from Magen David Adom. So we are here to share experiences, and I would like to point out that we are at the phase where we are sharing experiences that are not, I would call them, validated. As such, this is why each and every one of us is representing her or his own ideas. We did not have the time, and for the time being, we will not have the time to do a formal lessons learned exercise that are vetted through our senior management. So please don't look at whatever is said here as an institutional statement, but as a personal, I would say, educated experience presented by ourselves. And we believe that this is the right way of doing things. We were extremely, extremely lucky as Magen David Adom, being the emergency and national EMS for the state of Israel, that at the very, very beginning, and we will be forever thankful to the Italian Red Cross, here represented by Lorenzo, and to Paloma in Samur, Madrid, that in the very first 2 weeks of the pandemic, we said, okay, it's coming to Israel. We have friends that are already 2 weeks into this. Let's listen to whatever experience they have and they can share with us. And it helped us dramatically to improve our initial response. It's not that we did not make mistakes throughout the process. We made tons of them, but we try to do our own new mistakes and not duplicate others. And in the same manner, we try to share with other countries whatever we have learned. And I think that globally, we are much better doing things together than each and everyone doing it on ourselves and duplicating the errors that others have made. We have today a wonderful list of speakers, started with Andres from LES, a vendor, Eddie from Persis Medical, Chief Mike McVoy, from who is the EMS section chair, International Association of Fire Chiefs from the United States. Thank you, Mike, for being here so early for you. I apologize for that. As I already introduced you, Lorenzo from the Italian Red Cross, Paloma from Samur, Madrid. I hope that our friend Richard, who is from the HHS, which is the Federal Department of Health in the USA and leading a very interesting project called ECHO, will be able to join us out of a meeting. And the same Dr. Giovanni Nicoletti from the Italian Ministry of Health, who is leading with a new initiative of the European Union for joint procurement. And without further ado, Les, Andreas, the floor is yours, please. Andreas, you'll have to unmute yourself. Andreas, you're muted. Now we can hear you.
Lovely. So thanks a lot for the opportunity to talk at this occasion. Appreciate the invitation, Jane. You are clicking.
Yes, just let me know when you need the next slide.
So we are a manufacturer of emergency preparedness equipment in general, but everything we do has to do about preparedness. So we followed the COVID-19 development in China very closely, and we tried to have a dialogue with Norwegian health authorities and health companies and hospitals very early, but nothing really happened until it all hit us in the face. So one of the main product ranges is, of course, the CBRNE, including contagious diseases. So in this product segment, we have coveralls and respirators, tents and decon showers, and all sorts of personal protective equipment. And early March, the first product that we faced difficulty in finding supplies was one of the simplest products in our whole catalog. It was the splash shield. And we are packing ready-made kits for the ambulance services. And those kits included the splash shield. So we started immediately to produce the splash shield just to be able to supply the ambulance services that placed orders with us. It was a question of making a couple of hundreds, and we said that should be no problem for us to make with our left hand. But that was a very stupid thought we learned very fast. So next, please. All our efforts to talk about a pandemic on the way during January and February in Norway was all in vain. We had absolutely no interest, nobody listening to us, no sales. But on March 9, it exploded. And we had primary care companies, we had the hospitals crying, literally crying on the phone, lacking protective equipment. We had a run of emergency services coming to our offices like we have never seen before. So then we can move on. Actually, I need to just comment, the demand was all over the catalog. It was not only protective equipment, but it was tents and infrastructure to make testing facilities and so forth. So it was a whole lot of equipment. But of course, crisis number one was the COVID hitting us. But we immediately saw a crisis number two in parallel, and that was the closing of borders. It was a pretty chaotic supply chain challenge that specific countries stopped particular supplies. EU took charge of certain producers and rechanneled their merchandise. So it was a whole set of chaotic actions on a European level, or on country level, or on the Chinese government level when it comes to export out of China. Then we can look at the crisis number three. Next slide. So as all of this happened, we saw that planes were grounded, air freight capacity went to zero, and recovered slowly, and could represent maybe a 30% of normal capacity. And this, of course, resulted in enormous, humongous queues of merchandise sitting all over the world and not being transported to its destination. Prices went bananas, and it was a third level of chaos added on to the COVID crisis. And here in Norway, we had a crisis number four on the next slide. With a sudden drop in demand for petroleum products, the Norwegian crown lost its value by 40% in the few days from March 7 to March 20. And of course, you all can see the effect on pricing when you try to calculate products. You don't know where you are getting them from. You don't know at what cost you are buying them. You don't know when you are getting them. So the number of variables at play was really, really large. And this made a beautiful chaos for some chaos pilots like ourselves. So we had a tough time, but we managed to navigate through all of this. Next slide, please. So we were able to establish a production capacity in record time. First of all, for this this very simple product, the splash shield. So in 4 months, we were able to produce and deliver and source more than 600,000 splash shields to the Norwegian hospital purchasing organization. And that, of course, was a complex set of manning decisions, logistic decisions, and financing decisions. But it was a very interesting business case, because what we practiced during March, April, May is something you cannot learn in any business school. It has to be learned in a really complex chaos. Next slide. So for instance, trading products, we had for face masks, we had our 3M orders. They were stopped by health authorities, both on a European level and on a national level. They didn't care what we were using the face masks for. We actually packed them for the ambulance services, but supplies were just redirected to the hospitals. When it comes to tents, the whole world were demanding tents at the same time. So all major tent producers, they just ran out of capacity. And we all know what happened to PPE products. We were so lucky that we were working a face mask from Sweden, and this proved to be a really preparedness important issue. From Sweden, we did not have closed borders. We had a short distance. We could get the merchandise on truck, and that proved to be a very, very important topic for us. So in less than 6 months, we 10 times doubled the sales of these Tiki face masks. Next slide, please. So trying to look a little bit back, we feel that fantastic things really happen when a society declares a crisis, because then people really switch into a different mode. Not everybody are fast in switching that mode, but you have at least enough fast members of society, so you have teams to work with. Given all the complexity and the difficulties, we managed to serve our customers and deliver a turnover 5 times a normal year. And that in itself, that was, if we have a well-functioning supply chain, I think we could have done 15, maybe 20 times the turnover. So 5 times is very low because we had all the difficulties I mentioned previously. We see that there is a tremendous potential for improvement in private-public partnership. That dialogue, in our case, with Norwegian health authorities, did not work at all. And only with a small amount of better communication, this would improve the country's preparedness tremendously, with us and with other suppliers. Now we see clearly what the alternative cost of being unprepared. So how will this change our decision making for health preparedness in the future? At least we have a cost line to compare with all the tremendous costs that society has taken. We moved fast, but with caution. We have worked in crisis before. We knew a lot of buttons, how fast we needed to push them. We managed to avoid counterfeit issues and false documentation issues. That was a big part of this whole chaos. And we really hope that this immense global learning need to be explored, evaluated, and understood for the future, so we can actually get something good out of the crisis. That was my preparation, and as I say here, misfortunes never come singly. As soon as the dust started to fall to the ground and the corona situation was moving towards a more normal situation, we had our own disaster happening on February 26th, when our premises, both our factory, our warehouse and offices, all burnt down to the ground. But in less than 24 hours, we were back up and running with our business. We now see that the core products might take 12 months to be back in production, but more than 2/3 of the business is back to normal already. So we were prepared for our own crisis, and that is a great satisfaction. So I thank you for listening to to what I had to share.
Andres, thank you very much. First of all, I'm so happy that there were no casualties in that horrible fire, and hope you will be up and running really soon. Wonderful presentation. If I may, I would ask you one question, and you can choose not to answer it. And it's about the cultural differences or the difference in perception in the crisis management between Norway and Sweden? Did it have any impact on your collaboration?
Not really. Yes, there was a very different approach from the government side on how to respond, but it did not at all influence our business. We managed to work products both ways over the borders. We have a lot of Swedish customers also. So that were not subject to any hindrances. Actually, rather to the contrary. To work together with Sweden was so easy in a world where everything was complicated.
Very interesting. Thank you very much. So it's time to go to Persis Medical. Eddie, please.
Hi, Chaim. I'm, as was discussed in our emails, I will give the floor to Jasmine, she's our logistics manager.
Hi.
And she was actually in the front of when it all hit us. So I think it would be the best if she describes our normal life and then our challenges and how we tackle them. So Jasmine.
Hi, nice to meet you all. Next slide, please. Okay. Okay. This slide, I would like to show you the normal medical supply chain. Raw materials, shipping, productions, assembly, packing, sterilization, shipping and delivery, and so many times returns of materials goods. Next slide, please. The challenges in the air freight delivery, it was so many times canceling of most passengers' flights lead to increased demand of cargo space and increased shipping cost up to 4 times via air delivery. Airline priorities different cargo. It means that if you want that your cargo will be the first, you know you have to pay now up to 4 times. Increased demand from raw material suppliers. Some material suppliers had to produce material for the PPE instead of the regular production. Next slide, please. The challenges in the sea delivery, it increased shipping costs up to 3 times, canceling on delaying of shipping routes, container shortage. Some of the shipping companies have stopped routes from China and US to Israel. So if we only stay with 2 companies, they of course rise prices. Next slide, please. Suppliers, raw material suppliers could shift their priorities. PPE production and delivery became top priority. If you don't import the PPE materials, so you automatically became second in line. And if that's not enough, we got the Brexit. And the Brexit is unclear situation with shipping and taxes. We have our company at UK and also customers there. So the challenges came for us from both sides. The next slide, please. And how we staying effective and profitable. We're creating a backup pool of local raw material suppliers. This was necessary so that we could continue producing. Of course, this increased the cost of production. LCL partial sea shipping shared container with another exporters. Freight via courier delivery, different solution for automatic proceed before COVID-19. Before the COVID-19, in deliveries, Up to 100 kilo, we built the packages on pallet. And now we are sending them separately boxes via courier companies. It saves money, but the problem could be if not all the packages came together to the airport, and then the customer has to wait until all the packages came to process with the customs clearance. We always offer the customers the two options. Okay. Multiple price offers from courier companies, supply and demand. We always check with at least 2 shipping companies. Long-term production plan, large sea shipping. The next slide, please. Thank you for your time. And if someone has any questions, I will be happy to answer.
Thank you very much, and Jasmine, and let's go to Chief Mike McAvoy from the United States.
Okay.
Chief McAvoy, please.
Thank you. Everyone can hear me okay?
Loud and clear.
Okay, good. So I have only 4 slides, and I want to talk a little bit about our experience here in the United States. We are not proud to lead the world in COVID cases and COVID deaths, but obviously that had very significant impact on our healthcare and on our EMS system. And really there were 5 key supply chain issues for us, the most significant of which was PPE, personal protective equipment. And a lot of that was related to not having adequate stockpiles, either in our EMS services or what we refer to as SNS, which is a strategic national stockpile, did not appear to have either one the necessary resources for what we faced. And so that was a significant concern for all of our EMS services, and I think something that we will have to address going forward. And then we in the United States have really, because of cost cuts in the healthcare industry, made a lot of our products that we purchase outsourced to other countries where labor costs are cheaper, manufacturing costs are cheaper. And so much of the medical equipment and supplies that we purchase and PPE come from other countries. And so that posed a big problem, because in many cases, other countries were using their manufacturing capability to support their own countries and weren't able to send things to the United States. We had a huge increase in demand by non-healthcare entities. So all of a sudden, every citizen needed a mask, and people were buying hand sanitizer to use personally for businesses. And so that further drained the PPE supplies in the United States. And obviously, as we have heard from other presenters, there was a lot of price gouging, people hoarding and just panic buying. One of the amusing things here in the States, not related to PPE, was for over a month, you could not purchase toilet paper in the stores for some reason. People felt as though they had to stock up on it and fill their basement with toilet paper.
Mike, that's encouraging, because we thought that we are the only country who had that phenomena last March. So
glad to hear it was elsewhere. And then really very poor coordination was occurring. We had I refer on the slide to a Top Glove debacle. We all of a sudden, several months into the pandemic, completely lost our ability to obtain latex or nitrile gloves. And we did some investigation into why that was. And when we went to our suppliers, they said to us, well, really what has occurred is the major importer of gloves into the United States has been banned by our own customs people because of what they perceived as some child labor law violations. And so they were not permitted to move their gloves into the United States. And it basically, in an instant, cut off 80% of our supply of gloves. And that obviously was addressed internally and resolved. And shortly thereafter, we were once again able to obtain gloves, but it's an example of poor coordination and some of the issues that we experienced with PPE. So that was our first and probably most significant supply chain issue. And as Shane referred to, we have issues with equipment as well. And one of the major issues with equipment, again, is related to competition between vendors and healthcare cost cutting in the United States. And that is a very significant lack of standardization between equipment and devices. And so take, for example, a ventilator. Each company that manufactures a ventilator has their own specifications. They name the modes of the ventilator by their own trade name, and they don't share that information with other vendors in order to give them competitive advantage. And so because there was no standardization across the industry of medical devices, it became very difficult to quickly ramp up a manufacturing with another vendor, or to convert some of the manufacturing, like for example, auto plants, who people were not driving to work, they stopped buying cars. Auto plants were able to shift their manufacturing to create other materials such as ventilators, but it became very difficult to give them plans because there was really no consistent open source specifications for things like that. Regulation was a problem for us, and we had to work very closely with our government in order to allow use of products off-label, so to say, to be able to reuse an N95 mask, to be able to use a mask that was designed for a different purpose when it was useful in the medical field. So some of our regulations caused problems, not only for use, but also for manufacturing. And then we clearly had issues with other items that we needed. So in the EMS world, we all of a sudden were not able to get batteries for radios because those batteries came from another country. Our airline shipping was problematic to get something delivered overnight. As we heard earlier, the drop in passenger flights also caused a drop in being able to move cargo by air. And then shortly thereafter, our ability to move supplies around was inhibited by all of the companies that move materials like FedEx and UPS and all the air freight companies being involved in vaccine distribution. And so that put a crimp in our being able to move supplies as quickly as we needed to. It could go to the next slide, Jane. So our third issue was medications, and we in the United States, by federal government regulation, like to see our manufacturers have a 3-month supply of medications available. And very quickly, those supplies became used up. And the reason for that was that 2/3 of our raw materials that we use in the United States come from China. And it became very difficult to obtain those raw materials that were necessary to manufacture medications because many of the factories in China had closed down because of illness in the workers there, coupled with the transportation issues. So medications became particularly challenging for us and required our EMS systems to create the ability to substitute medications when we ran out of a medication. For example, breathing medications, we found an injectable alternative to that, or when we ran out of medication for paralysis, we would find another alternative to that. So it took some creative solutions. And supplies were also something that caught us by surprise. One of the early supply issues that we had was we had plenty of COVID testing kits, but we didn't have the swabs necessary to obtain the samples. And we realized that there were only 2 companies in the United States that made those swabs. And so we actually, here in my county, started printing them with a 3D printer so that we could have the swabs that we needed to do the sampling. So it took some very creative workarounds in order to resolve that. And then raw materials continue to be a problem, and some of that has to do with factories that are shuttered. Some of it has to do with border closures. So I live about 250 kilometers north of New York City in the state of New York. The Canadian border has been closed for over a year now, which has caused the price of lumber that we typically obtain from Canada to be 2-3 times what it normally would be. And we see that with other raw materials and other products that are necessary. There certainly continue to be choke points in shipping and bottlenecks with trucking. And some of the bottlenecks are caused again by illness and with difficulty with getting the workforce back to work, as well as export bans. So those continue to cause some difficulties with supplies. And our last issue was blood. We have a number of EMS systems that administer blood in the pre-hospital field. And we saw a huge drop-off in blood supply because donations are voluntary in the United States. And many people during COVID did not want to go to a donation center. And running a donation center became a big challenge. We oftentimes will run donation centers in the firehouses or in the EMS stations. And because of COVID, no visitors were allowed and no large gatherings were permitted. So it became a collection problem across the states. So solutions, nice to name problems, but I can tell you a little bit about our solutions. One of the first was we realized that it is much easier for us to purchase in bulk. And so I can give you an example. Here at home, my county that I run has a 250,000 population. My purchasing department in the county has for 30 years been the one group of people that I hate the most. Because they're always asking me for like, oh, you need 4 bids on this, you need 5 bids. Why can't you use the lowest bid? All of a sudden, the purchasing department became one of my best friends. They would call a vendor and tell the vendor, so your vendors on the call can cover your ears. They would call the vendor and say, we are the government, and so we need to find out where you're obtaining these supplies from. And they would say, we just need to determine where the original source of it is. And they would jump all the way to the manufacturer and be able to purchase the supplies in massive quantity. So there were many times when I was having a plane fly into one of our airports and bringing supplies directly into the county from other countries. And that bulk purchasing turned out to be a method that we were able to purchase things where we were not able to get them directly through the usual suppliers that we were ordinarily using. And then the other thing, and I've talked about this on previous calls, that I think some of the hoarding that happened and some of the panic buying was able to be alleviated here in the States by taking large quantities of materials that came from stockpiles that the government had, and whether that's federal government or state or local government, distributing those materials. So I was able to essentially oversupply most of my EMS services and make sure that they had everything that they needed to operate with. And as soon as we were able to do that, we saw that the hoarding stopped and people were then interested in sharing supplies with their neighbor and making sure that everyone had the goods that they needed to do their job. And I think that was a lesson that I learned personally as a way of being able to manage the total supply chain. And it can be a little bit nerve-wracking to do because you're actually using a great deal of what you have in stockpile in order to do that. But it turned out to be one of the ways that we were able to assure that the goods that were necessary out there were distributed equitably, as opposed to people taking advantage of a situation and hoarding things. We also learned that we need stockpiles, and I don't know, I can see from the gray hair on the call that many of you have been around for quite some time. And I know in the States, many years ago, we had large caches of materials that were used in civil defense centers where we were preparing for some kind of nuclear Armageddon. And we had cots and food and antibiotics and surgical supplies, and they were stashed in locations all around the nation. I think that we're going to move back to that. We're struggling right now with places to store some of the stockpiles that we're now creating. So many of our EMS agencies have recognized that this could happen again. We need to increase the quantity of gloves and PPE and other equipment and supplies that we have on hand. And storage has become a very big issue for us. And I think that's going to be a concern moving forward here. The next point is trying to predict the future. And I think the sooner that we can predict the future with this event is in our advantage. And I'll give you an example. We recognized very early on that there was going to be vaccines. And so to prepare for vaccines, we realized that we needed syringes and needles and alcohol preps and Band-Aids. And so we began to order those in the hundreds and thousands so that we were prepared. That turned out to be very helpful to us because those items are now extremely difficult to acquire. And so we have the supplies that we need to vaccinate our entire community because we predicted that that was something that was part of this pandemic that was going to affect us in the future. And it's difficult all the time to think ahead like that, but I think that's a lesson that we learned from this, which probably all of us need to do each day. And finally, innovation. And so there's a picture here of the New York City Fire Department who has switched from using N95 masks to elastomeric masks. And so these are masks with a disposable filter that has a lifespan of somewhere between 6 and 10 months before the filter needs to be changed. The mask can be washed and cleaned in between uses and retained by the individual paramedic. Solve the problem for both the discomfort of the N95 mask and the protection that it provides to the paramedics. And so that's an innovation that has come out of this pandemic. And I think there are many others that we'll see when we look back at what we're doing. But that's an example of some of the things that our providers and our EMS agencies have done in the country to attempt to resolve some of the supply chain problems that we're seeing. So that's in a nutshell some of how we see things with the fire service and EMS here in the States. And I see Dr. Hunt is on the call also, and he may have some other things to contribute, or I don't know, James, is he presenting later?
Yeah, he's presenting.
Okay, all right, good.
Mike, thank you very much. I have to say that I'm hearing a very interesting theme because we are always in crisis management talking about disaster as an opportunity. And what I'm hearing throughout the presentation so far is the many good things that came out of the pandemic with all its horrific outcomes. And I think that this is something that in many cases is overlooked And there are really great things that an innovation that is coming out. And I would like to hand over to our friend Lorenzo from the Italian Red Cross. Lorenzo, prego.
Thank you, Chaim. Thank you, everybody. So I work in the emergency planning sector of the Italian Red Cross. So I will try to give you an overview of what is the supply chain and which are the main supply chain principles that we define. A little bit tailored for COVID-19, and then go a little bit more in depth of the challenges we met and we are still facing during this long-term slow onset emergency. So and then when we're talking about emergency supply chain, we consider both procurement phase and where procurement is both related with donors and supplier from my perspective, or everything related to the internal management and then how we can serve the people in need. So all the operations that are towards the people. So we can have we will discuss a little bit of the challenges that we faced on the so far side of the supply chain and today then the near or the last mile of the supply chain. So when we are effectively reaching the people in need. Thanks, Chaim. So just zooming in a little bit on the supply chain. First of all, I completely agree on the fact that procurement played a major role. In the procurement phase, here you put everything like administration, finance, accountability, effectively procurement office, donors, partnership and relations, and so on. Because what we had to do is to try to coordinate all this and to coordinate it in receiving goods that we effectively were in need of. What we try to do is behind all the supply chain to have a quite good data management. So when we and to have a supply chain data driven, that's something that we should consider as so data are part of the supply chain, informations are part of the supply chain. It's just a way to how we normally perceive them, but they're fundamental to support decision making, not only for so strategic or policy level decisions, but also at for logistics. So then at internal management level, we had to consider continuous situation analysis and needs. When we said situation analysis, we had to count on our network of emergency operations centers, and we are counting around 670, 640 branches. So it means 640 local emergency operations centers and 22 regional operational emergency operations centers. So we're channeling situation analysis and analysis through them. Then thanks to our training center and thanks to external training centers, we had to work on specific trainings because we were dealing with new PPEs, we were dealing with new materials, so we were in need of certification, not only for the products, but also for the personnel that has to use it. And all the logistics, warehousing for sure, transportation, but customs clearances. This was a little bit of an issue because at a certain moment the country had to custom clear goods that are normally cannot be imported. So they have to define new way to certify that products are good enough to be used. And then the operation side. So SON is in Italian the National Operations and the Emergency Operations Center, and we had to work on mobilization. So it's true that we have to work and we were in need of goods, but we are also in need of personnel. In a moment where the whole world was were searching for medical personnel, and we're mainly working with volunteers, and we have medical personnel being a volunteer. So they had to decide, okay, what can I do for the Red Cross and what can I do for my hospital or my place where I work? And this is still one of the biggest issues today. And then how we can continuously manage the normal way we do, like, okay, we have mobilization, operations, demobilization, and post mission. Okay, but we don't need to wait 2 years for having a good debriefing and a good best practices analysis. We need to do that on the run. So we had to close this circle before, and having elements coming from post mission and debriefing inputted into the supply chain management to understand where we can better support all the chain. Last but not least, people in need. We're providing a lot of different services, and we are doing that at the same time. So from ambulance service, EMS, to bringing goods to people. So relief AD distribution. We normally, our normal habits is to deliver, so for free, relief ID for the people in need. But then we were a new kind of beneficiary. People in need that were completely able to buy the goods for sort of like groceries or whatever they need, but they cannot do that because they cannot move from home. So how we can ensure them to receive their goods, at the same time how we can ensure the management of the payment of those goods without passing through a massive purchase through the Italian Red Cross. Then, talking about yeah, thanks, Jaime. Talking about custom clearances, in agreement with the national government and the Civil Protection Department, we supported two main hubs, one in Malpensa Airport near Milan, and one in Fiumicino Airport near Rome, providing personnel to support the custom clearances. Just to give you some figures, our personal support custom clearances for more than 140 million of pieces during 2020. When we say support, it's not that they were doing the bureaucracy part related to, so that normally is made by the customs, but support the identification of the different kind of the different type of PPEs, what is needed, what is not, and so on, in cooperation, in agreement, integrated into the system. The other dot, the other red dot here, is our main warehouse that is in Avezzano. It's a 75 hectares area. So where that you are using as the main warehouse. And so, but it's not the only warehouse we had to manage. So unless to centralize everything here and then deploy, as we do for a lot of times, for a lot of things, for COVID-19, we use the whole network of our emergency operation response center that we have at national level. Thanks, Hein. So I know the you see elements written in Italian. I don't care about that. But the red dots are our National Response Center, where they are, and through them we channel the transportation of all different kind of goods to the regions around, and from the regional branches to the local branches in the whole country. Consider that during the first wave, the most affected part of the country was the northern part of the country. So fortunately, the area where we have more and more capacities, and I'm thinking about the whole system. But then right now we have a situation that is considering the whole country itself. So we had to reorganize, continuously assess, and then reorganize all the logistics support. In terms of the way we try to face the need for data and the need for precise analysis was to so somehow
Lorenzo?
Yep.
3 more minutes, please.
Okay. So the way we tried to manage all the information was to organize an automatic reporting system. So it means that all the 600 local emergency operations center automatically send a report to all the chain of command, and with an information management team that was working on the databases, analyzing the data, and sending back information to the whole chain of command at the same time. So I ended. I've just 3 points. I completely agree with Chief Mark McAvoy about the fact that we are losing the effects of the Cold War era emergency plans. So we all are very, very focused on localized emergencies, big enough emergencies like earthquakes or things like that. But nationwide or continent-wide disasters or situations that are involving not only localized response capacities or projected response capacities, but also the possibility that nobody can help you at the moment is something that is not in the plan nowadays, or it is right now, but it wasn't in the plan nowadays. Then I think I touched more or less everything, so I'm here for questions.
Lorenzo, grazie mille. Before we move ahead, I would just want to point out one thing. What we see in Israel, who seems to be stepping out of the woods to a degree from the actual health crisis, we are shifting very fast into focus on economy. And I think that when we say we need stockpiles and to be ready, to be better prepared with our stockpiles and local capacity for the next emergency, we are going to have a huge fight on money, on the investment that the healthcare system will get in the coming years, understanding the huge expenditure that we saw during the last year. In Israel, it was basically whatever you need in the healthcare system, you get it. And I'm sure that our Ministry of Finance will have now the approach that, guys, you got in 1 year what you didn't get in 20, which is absolutely true. So you will have to manage in the coming 20 years with no money, basically, because you got it all during COVID. And that's going to be a huge political fight that I don't know what will be the results, but that's another discussion. So with great pleasure, I hand over to Paloma Rey from SAMUR Protección Civil Madrid. Paloma, por favor.
Okay, good morning, Mike. Good afternoon and good evening for the rest of colleagues. Thank you for attending this webinar related to one of the most important issues that COVID-19 pandemic has brought, which is the vulnerability of the medical product supply. The vulnerability of a medical product supply has historically attracted little interest from the healthcare managers in the developed countries. Now, COVID-19 pandemic has made obvious that product shortages affect not only clinical practice, but also to the organizational performance, the patient outcomes, and of course, the safety of the healthcare workers. The purpose of my short presentation is to share our experience and main challenges during COVID-19 in SAMUR Madrid. Okay, SAMUR is as emergency medical services depending on the City Council of Madrid. And during the first wave of the pandemic, we performed the following activities, mainly during the first wave. The emergency medical assistance to patients with mild, moderate, or in critical condition, unaware of their infective status. Logistical and medical support to a contingency hospital to set up to address the expected high demand for care of an increased number of patients with mild or moderate respiratory distress. Healthcare and organizational support to nursing homes, mainly in Madrid, as they were overworked. Next, please. Another activity carried out was medical transport between health facilities, mainly hospitals and medicalized hotels, and also nursing homes. Outside our scope of action, SAMUR provided medical support to other regions in Spain. And the last but not least activity was the contamination of the medical vehicles and personnel after each intervention with a suspected or confirmed COVID patients. That had the objective to keep the advanced life support and basic life support units operative for as long as possible. Next, please. Okay, our key challenges during the pandemic has been the shortages of PPEs and medical products, not only all over the country, even all Europe, that threatened the goal to deliver the right care to the right person at the right time. Fortunately, we had stored PPEs from the Ebola cases we had in 2014, and that could be used at the very beginning of the pandemic. Until the purchased material arrived, we used materials donated by individuals and private companies also. In the beginning of the pandemic, the market was free and open, and sometimes after the purchase was closed, negotiated and closed, it could be cancelled by the seller to be sold to another buyer who paid more money. Additional challenges arise when companies fail to comply with the regulatory requirements in order to reduce the risks of defective products. Purchases were made by the municipal government, which is a public administration. So there was a risk of buying products at a cheaper price from non-certified suppliers. That's why extraordinary supervision of the compliance with the Ministry of Health specification was necessary. As a first measure, the individual protection of workers was oversized. This thing provided confidence against an unknown virus. High-level protections and the reinforcement of auxiliary services like cleaning in the headquarters and operational stations, extra disinfections of the ambulances, etc., helped to generate confidence among workers. And also there were quick changes in the personal protection criteria. For example, 10% bleach solution was initially used to disinfect the healthcare workers, the health workers' shoes, but that concentrations damaged the material, so it was lowered to 2% solution, equally effective. Another example was when the Tyvek suit was changed to reusable gowns. All this information about the protection and everything was reinforced every day in briefings to clarify concepts and dispel fears. Next, please. Another challenges was setting up of a decontamination line only for COVID cases around the clock. Before the pandemic, total discharge aerosol was used to disinfect the ambulances. Now we have almost 20 different virucidal products carried in gas or liquid flow. Medical personnel has to adapt their performance to the new materials and equipment. And medical supplies were stored in a centralized and specific warehouse, depending on the General Directorate of Emergencies and Civil Protection, from which the material was distributed to SAMUR. Purchases were multiplied due to the unknown duration of the pandemic, and because more protective material was used than in regular activity. The goal was and still is to be self-sufficient for as long as possible. Next, please. Regarding the solutions reached by SAMUR, we highlight the following. The Municipal Emergency Territorial Plan of the Madrid City Council was declared. This declaration implied the setting up of a general warehouse to store all the material to be used to fight the COVID-19 in all municipal services, including SAMUR, of course. The purchases were centralized through the City Council, and all the supplies are sent to that general warehouse. Once there, the medical supervisor from SAMUR check and organize the distribution to the municipal services. External solutions taken by the municipal government were to regulate the purchase of supplies through a framework agreement. The City Council establishes reference materials with technical specifications and price ranges and tenders out them, so that the municipal services can buy any product with this basis with the objective of an easy purchase, to have a general stock, and also to get a price adjustment. Next, please. To conclude, some of our challenges for the future are to keep continuously over time a centralized warehouse for storage of disaster response material, to maintain a minimum stock controlling the expiry dates of products with the objective of ensure the supply of unusual or special equipment, and stay away from fraudulent medical supplies companies that has been another issue during this time. And this is all. Next, please. Thank you very much for your attention, and Paloma Mirabet and I will be pleased to answer any question.
Paloma and Paloma, muchísimas gracias. And now I have the pleasure and the honor to invite Dr. Richard Hunt from the HHS in the United States. And Richard, I would kindly ask you also to speak, if you can, a little bit about the ECHO project, which I think is a wonderful one. So, Richard.
Yeah, Chaim, I appreciate the invitation to join you today. And actually, any remarks I make on supply chain here are absolutely informed by the HHS ASPR sponsored, supported Project ECHO COVID-19 clinical rounds, which actually, Chaim, it's actually fascinating to think that the very first COVID-19 clinical rounds we did was 1 year ago today on March 24th, 2020. Tragic that we had to do so many, but indeed that happened to be the case with a pandemic that nobody could have predicted its course. The COVID-19 clinical rounds were quickly developed in March of last year. When I say quickly, over about a week's time, literally over a week's time, developed as a peer-to-peer learning platform for clinicians, with a goal of learning about experiences of clinicians in caring for patients and clinical operations as related to COVID-19. In the with a real different slant from a webinar. Essentially, these are clinicians sharing their experiences in patient care and clinical operations with other clinicians, because there was no evidence. There was no disease, COVID-19, until a little over a year ago. So there weren't presentations of peer-reviewed studies. It was basically clinicians sharing what's working and what's not working. We have 3 series of rounds. One's EMS that occurs on Mondays, and Chaim has been gracious enough to join us on some of those rounds. They're open to any clinician or EMS administrator, just simply by registering. We also have a series on critical care and a series on emergency department, thinking that those were and seem to have been the quote unquote choke points, or really critical points in accessing acute care. To date, we've done over 130 rounds with over 45,000 participants from all states, and then multiple countries, usually ranges from 2 to maybe 6 countries per session. So that's an overview of the rounds. So my comments on chain issues are really informed by those by clinicians talking about their experiences on the rounds. And then we also have during rounds a polling function by which we ask participants about issues that seem to be really pertinent in the moment. And supply chain certainly was one of the issues, and PPE in particular, certainly early on and mid-course during the pandemic. So some observations from those participants, and mostly from the polling. One was, it was pretty clear that clinicians, when asked about where things were with their access to personal protective equipment, early on, N95 masks were a huge problem. Over time, that then, as Mike McAvoy alluded to, then it evolved into gloves being short. Then it evolved to gowns being short. Another thing that occurred early on was, as I was listening to a number of meetings of supply chain experts, healthcare administration, subject matter expertise, that what the clinicians, including EMS, were being faced with in terms of their access to PPE wasn't the same as what we were hearing from the supply chain expertise. There was, and I think to me, and I think to the participants, it really highlighted the issue of, okay, what the end user is actually seeing and experience may not be the same as what a supply chain expert sees on his end. There's a lot of room between what the two of those are seeing and experiencing, and it's really important to connect those dots. And I recall after one polling where so many had difficulties in access N95, and I had heard, well, we've got a lot of great N95 supply now, it's all taken care of. And the ability, or not ability, but the need to connect what's happening in the real world at the bedside with what those further upstream in terms of supply chain are seeing is really critical. So why is it that they're not quite getting it yet? And what are those points in the chain that are still blockades? So at any rate, that was a real sort of a learning point during the rounds. The other was, I recall one of the very first polling set of questions I had was like, do you have access today, for example, N95, masks, gloves, gowns, et cetera, et cetera. And then somebody put in the chat, well, you need to have the option adequate N95s. So it's not just like the name itself, but are they adequate? And adequate code for, are they like counterfeit? Are they like so cheap, cheaply made that they're really not serving the purpose, et cetera, et cetera. So it's not just like the name of it, but are they actually effective in doing what they were intended to do? That was a big sort of like take home. And that became a huge point made by all, that it's not just the name of the equipment supply, but are they actually effective at doing what they were intended to? Then the other piece that occurred when we had such vast shortages, just awful shortages, was the issue of being able to use preservation strategies. And what were the strategies that you could use as alternate strategies that might not get you perfection in PPE, but get you at least some protection? Again, the name we talked about with that would be preservation strategies. And that led towards some of that innovation that Mike talked about with the elastomerics and other preservation strategies as well. When we knew that there just wasn't enough supply, and the end user, the clinician, said, yeah, there's not enough supply, and you know, we're going to die out here without getting adequate PPE. We spent a lot of energy on really not just developing those preservation strategies, but informing clinicians of those strategies. And I think there was a real reluctance early on to use anything but perfection. And then there was, as time went on, a realization, well, you know, perfection isn't going to come. We got to figure out this preservation strategy that led then to, for example, the implementation of the elastomerics. The other thing I would say in terms of supply chain, and specifically around not equipment, but the PPE supplies, with EMS, especially EMS, was the issue of fatigue and compliance and actually following PPE protocols. People are worn out. They got worn out. They're tired of it, and understanding that, but how to get to the compliance issue and how to get to the fatigue issue, specifically around PPE, so they can save their own lives and the lives of others, is a really critical one with this whole PPE thing. And then the other thing is, I think that the silver lining, Hyman, I think you really hit the nail on the head. Where's the opportunity, and how can we find the silver linings for this? It's my observation that infectious disease and EMS has not always, infectious disease diseases haven't been high on the radar screen of EMS. It's sort of like it's there, but how much attention do we need to pay to it? And I think that the pandemic certainly highlighted that in just a profound way. And I'm hopeful that some of what we have learned through this pandemic doesn't disappear, much like some of the, the Cold War stockpile issue that was discussed earlier. I hope we get this figured out and can be sustained and not forgotten. And that's going to be our challenge, I think, moving forward. Chaim, back to you. Thanks.
Thank you very, very much, Richard. And I strongly invite all those of you who are interested to join the ECHO sharing opportunities. For me and for Magenta Vidadonda are extremely valuable. I will share with you the link. So please join and invite your colleagues to either one of the three of them. They are extremely valuable. An hour a week that is worth devoting to this activity. So Richard, thank you very much for the invitation and the opportunity. And our last speaker is Dr. Giovanni Nicoletti. Dr. Nicoletti, please.
Yes, good afternoon, and thanks for this invitation to this very interesting workshop. I see that I'm the last, but probably I'm also a bit a stranger among you, considering that you are all long experienced people with supply chain, while I'm just a senior medical officer of the Ministry of Health. That has happened to many other people in Italy due to COVID-19 emergency. I was somewhat reconverted to be an operator of emergency situations. And so you will forgive me if I'm not as experienced as you are. I'm just here to recall some experience that we had in this particular situation, both in Italy and in the European Union institutions. In fact, my personal work in a previous life was international relations, and in particular EU project management. And in this role, I had strong relation with a number of units in the European Commissions that were also partially or totally reconverted to support the countries in this emergency. As you might remember, Italy was severely hit by the emergency somewhat sooner than the other EU countries. And so the result was that Italy has many difficulties while other countries were still thinking if there was an emergency or not. And to this, following this path, also the European Union institutions were somewhat lazy to react to the first phase of the emergency. While when the emergency hit Italy, there was a reconsideration of the situation, and several things happened that, as somebody else mentioned, did not happen in the 20 years before. In particular, the Commission, due to political and financial commitments, also tried to understand if it could be a role of the Commission, not just in terms of political willingness and coordination, but also in terms of supporting operationally the countries more in need. If we get back to last year and we recall what happened in March and early in April, not only there was no coordination at the European level, but on the contrary, there was some sort of arguments among the member states because there were seizures of PPEs. There were some member states blocking transports when there were stopovers in their countries coming from China or from other sources. So there was really a competition among the countries to safeguard their own populations, independently if this could have consequences on other member states. That was one of the reasons why the Commission tried to act in person and to try to find some kind of solution for this situation. And clearly the new legislation and new political agreements were conducted, but also the operational units of the Commission tried to use some of the very few tools that were existing at the moment in order to support member states. And in practice, the main tool that was identified was this joint procurement agreement, a relatively neglected act that was adopted several years ago after the crisis of the 2009 flu epidemic, that had mainly the scope of putting the member states and the commission together in order to manage negotiations with big pharma and vaccine producers in order to reduce costs for and improve and ameliorate the negotiations, in particular for small countries, which had and still have a very limited power of negotiation when they have to deal with this kind of issue. But the tool of the joint procurement agreement was in practice never tested, except for one contract that was stipulated several years ago for a potential preparation of a future pandemic influenza vaccine. But that was all that we had. So the idea of using the joint procurement agreement was stimulating, but regretfully, the tool was not designed for emergency situations. So it still had a lot of challenges, in particular related to the fact that it is fully respecting the European rules on public procurement. So there is a need of transparency and thorough examinations of the offer, transparency and publicity of the bids. So a lot of very important rules, which, however, are not so very applicable during an emergency. As a result, the Commission launched several tenders related to a number of elements. I just mentioned one: PPEs, ventilators for intensive care units, molecular tests and antigen tests for COVID-19, drugs for therapeutics, in particular for intensive care use, and then specific drugs and therapeutics for COVID-19, like remdesivir and monoclonal antibodies more recently. Another very important branch of the application of the joint procurement agreement was clearly the joint procurement of vaccines, which is still ongoing, which, however, followed a more politically oriented and managed process, considering clearly the enormous amount of money involved and the high importance, political importance of finding a common way forward for vaccine procurement. And we still see now some challenges related to vaccine procurement, as you all know. Considering the pros and cons, we can mention very briefly that most of these procedures were successful, but they were time consuming, and in some instances, several countries, including Italy, could not take profit 100% of the results achieved by the procurement procedures, either because they were arriving too late compared to the emergency, and on the other part, because most of the companies did not provide enough number or enough quantities of the tools and premises as much as were needed by the countries, or better to say, they were able to provide it in the medium term, but not in the short term, with some exception. One successful story was the procurement of remdesivir, mainly due to the fact that it was the company policy, this Gilead Sciences, not to have negotiations with individual European countries, but to negotiate only with the Commission and the member states together in order to provide to a single price and within a single framework contract all the required drug. This is partially a success story because it granted the access to this drug in a relatively difficult time, though when most of the availability of the drug arrived when the first wave of the emergency was finished, but it was right in time for the second and third wave. So it was very important for all the countries to have this possibility. Another situation which is more or less going the same way is the purchasement of antibodies for COVID-19, with the difference that some member states had already concluded in a very early phase agreements with some of the companies in order also to support some experimental use or emergency use of the drug, while others, including Italy, were more cautious in introducing this kind of therapeutics. And so the results were that also the public purchasement at the European level was somewhat slowed down. Just to conclude this intervention, clearly this experience is now informing many of the decisions at the political level, at the EU level, concerning renewal of the emergency legislation on health threats. And as you know, there is a proposal from the Commission, which I think will be also supported by the member states, though the details are still to be defined, setting up a new emergency agency, which will include, among others in the mandate, the possibility of making direct purchasement, not just for stockpiling, but also for the management during emergency situations. And also the possibility for the Commission to declare an emergency situation in Europe in order to let apply specific rules for public purchasement, but also for avoiding the problem of potential member states' egoism that happened at least during the first phase of the COVID-19. Thanks again for this invitation. I hope to have been enough synthetic but understandable, and thanks again.
Grazie mille, Doctor. I would like just to make the comment that finally we have managed to bring together the policymakers, the suppliers, and the end users into one webinar to really look into the issue from the different angles that I think with the same objective, we still have some different views. And it's important to see all the different views so we can move forward better. Before concluding, Luca, our project manager, would you like to say some concluding words?
Thank you, Jaime. Just a very, very brief thank you to you, Jaime, for organizing this webinar, but also to all the speakers. I would like to really thank you because this activity, these webinars are very important for our project, but for sure not only for us, but for all the network of practitioners we are working to enhance and build. So we thank you again. We will take good care of all this information, and we will try to deliver to the largest majority of practitioners in Europe and beyond. Thank you very much.
Thank you, Luca. Thank you to everyone. First of all, to the speakers. Thank you so much. To Natasha, on behalf of our networks, and to the whole team of Work Package 4 who is working with that on that for the whole COVID outbreak, a very hard year. And I have to, from the bottom of my heart, thank everyone on Work Package 4 for dedicating the time, and so many friends outside of the project that have dedicated their time and shared their experience despite of all the stress and the workload. So thank you so much. On the slide, you see the word hope in Hebrew that comes with the vials of the vaccine, of course. This Saturday, we will be celebrating the Passover night. And in the Jewish tradition, the blessing for Passover is that Passover is a festivity that symbols going out from esclaviture to freedom. And the most common wish is that we will go out from the darkness to a big light. So I really hope that for all of us, this is the end of a very, very challenging year with a much better year ahead of us. So thank you so much again. Please stay safe, take care of yourself, yours, and your team. And we will see you around after the holidays, as we say in Israel, in our next webinar. So thank you so much.